Okay, right now it's time, I think it's 3:05 p.m. so we can start the meeting. I want to welcome everybody to Ankara University webinar series. Today our guest is the president of WOFAPS. He's a very good friend of mine, Sameh Sheata. He's practicing in University of Alexandria, Egypt. He's right now the president of WOFAPS, as I already told. And he is also the past president of Egyptian Association of Pediatric Surgeons. And he is also the past president of IPEC Middle East chapter. We have been together in many courses, many congresses, and he is such a big and nice figure in world of pediatric surgery. And today we are going to talk about how to avoid complication in Hirschsprung's disease from him. So please excuse me, the other international participants, but I have to say some words in Turkish for our Turkish participants. And then I will give you the words so you can start. Herkese merhaba diyorum. Toplantımıza hoş geldiniz. Bugün gene uluslararası bir toplantı oluyor. Yani dünyanın farklı yerlerinden pek çok çocuk cerrahı bu toplantımıza katılıyor şu anda. Sameh Sheata bizim çok iyi bir arkadaşımız. Dünya Çocuk Cerrahisi Derneği'nin şu anda başkanlığını yapıyor. Ama Dünya Çocuk Cerrahisi camiasında da önemli bir figür kendisi. Özellikle endoskopik cerrahiye olan ilgisi, Mısır'ın uluslararası alana açılmasındaki büyük katkısı, hem endoskopik cerrahide hem çocuk cerrahisinde onun gerçekten önemli atılımlar yapmasını sağlaması açısından önemli. Şimdi çok fazla sözü uzatmadan ona vereceğim. Bu seferki toplantımız sırasında bir takım anket soruları da olacak. Sameh toplantı sırasında kendisi bunları bildirecek. Ondan sonra da ona göre siz de oynamalara katılabileceksiniz. Sorular için gene participants kısmından el kaldırmanız gerekiyor. Ona göre ya da kendiniz isterseniz soruları sorabilirsiniz. Gene bu toplantıda da host olarak ben olacağım. Dolayısıyla ona göre herkese söz vereceğim. I was telling to our Turkish friends that there will be some ongoing online polls during the presentation. And you are going to explain them how to use their polls, I think. And at the end of the presentation, of course, there will be some questions and comments. So I will direct you the questions and comments as well. So please go ahead. And we are really very eager to listen here.
Thank you so much, Aydın. Now I share my screen. Well, at the beginning, I would like to thank Aydın and all our Turkish colleagues for this wonderful invitation to join you today to talk about Hirschsprung disease. And my topic is about how to avoid complications in surgery for Hirschsprung disease. So, well, we had a long history of collaboration with our Turkish colleagues since a long time. Many congresses either in Turkey or around the world. Most of them are personal friends. They are unique and they are adding a lot through their experience and their publications to the knowledge and experience of pediatric surgery. We have some serious moments and some funny moments during travels and social visits, but this is a very strong bond between Egyptian and Turkish through many collaboration of the WOFAPS, the EPSA, the Turkish Association of Pediatric Surgery, and many other associations. So let me talk about the topics to be covered today. I'm going to talk about imaging, what are the mistakes and pitfalls in imaging, the biopsy, what is the minimum age you can do one stage pull through, and some technical pitfalls during surgery. Well, the three problems after surgery for Hirschsprung disease, how to avoid soiling and incontinence, the constipation and enterocolitis. Well, my sources are international literature with very important and landmark publications. Of course, the strongest is meta-analysis and systemic surveys, together with the national experiences and publications from Egypt, and to be added to personal experience. I'm personally interested in Hirschsprung disease for more than 25 years. So these are my three sources for information in this talk. Well, this is one of the multi-center studies in Egypt about Hirschsprung disease. Some time ago, this was 2004, with the collaboration of 4 centers in Egypt about the Hirschsprung disease using the transanal approach. And it resulted in some important messages and guidelines. So let's start with how to avoid imaging pitfalls. If you look at this contrast enema, you can see it's not easy to see if there is a short segment involved or not, because there is a pitfall here. I'm sure you see it. The balloon is distending the lower rectum. You cannot see there. And whenever you see the rectal balloon, you can see here a short, narrow segment. That's essential for the diagnosis of Hirschsprung disease. You can see it here. Again, the importance of lateral view over the anteroposterior. You can see here an anteroposterior view. You cannot see clearly the region of importance, while if you try to look at the lateral view very clearly, you can see how clear is the narrow segment. Do you think this is too crowded? Sometimes there is a lot of intestinal loose. You cannot see exactly the details. I advise you wait for 24 hours and take another delayed film. You see much better details. You see the retention of dye, and you see the discrepancy and the dilatation much more. So to summarize, the proper technique of contrast enema: stop bowel preparation 12 hours, avoid inflating the balloon, take an anteroposterior and lateral view, and take 24-hour delayed film. What we are looking for in contrast enema, actually these regions: 1, narrow segment, reversal of rectosigmoid index; 2, the cone of transition; 3, abnormally dilated bowel; and 4, a normal caliber looking colon above. So if you see 4 zones, then this is a very strong predictability of Hirschsprung disease in this case. Then how to avoid pitfalls during biopsy. This is a very nice publication by Dr. DILATED about the error traps and culture of safety in Hirschsprung disease. Among the features, that when you take a mucosal biopsy, like the rectal biopsy, for example, a mistake is to take only the mucosa and leaving the submucosa. The ganglia actually are in this region, the submucosa. And if you take a superficial biopsy, you will miss the ganglia and have a false negative result. If you take a seromuscular biopsy, like in open surgery or laparoscopy, if you take this superficial biopsy, again, you will miss the location of the ganglia. The ganglia are in between the 2 muscle layers, so you need to take a deeper biopsy, including all the muscle layer, the longitudinal and the circle. Of course, the most accurate is the intraoperative full thickness biopsy, where you combine all the submucosal and the myenteric muscular ganglia. Now we go to our poll number 1. You will be given 60 seconds to answer the question: what is the minimum age for one-stage pull-through? It is possible to do at very young age, but is it safe or not? Let's see the poll. Okay. Now we need the question about the minimum age. Question number 1. Yes, that's it. What is the minimum age for one-stage pull-through? I can operate anytime. Above 1 month, above 2 months, above 3 months, this is your choice. So let's see and let's go back to the literature and see what the literature will say about the age, minimum age for surgery. We'll give 60 seconds for you to vote, and then we'll publish the results. Okay, we can end now and share the results. Yeah, let's look at this. It's almost split. I can operate at any time. This is 24% of the cases and about 3 months in 35. So it is almost split opinion. So let's go and see how the literature will talk about this. Well, this is a multi-center study that came from China 2017, and it mentioned that performing single-stage transanal pull-through in non-neonatal period may be more appropriate than in the neonatal period. And it has been reported that this is a big study on large number of cases, that operating in neonates, although it's easy, I know a lot of people can do it, they are expert enough to do it, but in neonates, there are higher rates of perianal excoriation, anastomotic stricture, leakage, enterocolitis, and incontinence. So although it is possible, yet I advise you, I personally, my personal protocol is try as much as possible to operate above the age of 2 months. And then there's another point. This comes from China 2020. This is a very recent article. Do you use preoperative anal dilatation? I personally, I use it since long time. This publication is in 2020, but since long time I'm using preoperative anal dilatation. It has been concluded that it does not reduce enterocolitis or postoperative obstructive symptoms, but it may decrease the difficulties of surgery and the operative time is shorter. So making the anus a little bit dilated before surgery, make the surgery faster and easier. So how much anal stretch do we need to perform surgery? Because doing an operation through the anal orifice is a bit claustrophobic for some surgeons. How much anal stretch do we need? So if you look at this, we see it from other people work and publication, too much anal stretch to be comfortable during surgery. Well, I must say we have to stop this completely because excessive anal stretch will lead to injury and weakness of the sphincter. And what in the most of the cases you can do the whole operation with a little bit of stretch, minimal traction. You don't need more than 1 inch to 3 centimeters of anal stretch during the whole surgery. So completely avoid excessive anal stretch. Even at some part of the operation, the retractor hooks will fall and you can do a lot of steps, as you can see here, without retractor or stitches at all. Then how much anal mucosa we need to keep? This is a very important study from the APSA Hirschsprung disease interest group by DeLatour, Langer, and Mark Levitt. And they recommend, this is again from the error traps by DeLatour. This is a beautiful photo, operative photo, to show you where exactly you start your dissection, where is the incision in the mucosa, and where is the anastomosis. It has been recommended that you have at least 1.5 to 2 centimeters above the dentate line where you make you start your incision and your anastomosis. You go here, and this is what I call the $1 million piece of mucosa, responsible for the sensory reflex of continence. This is very sensitive area. It feels the coming stools. It's called the sampling reflex. And you need at all costs to keep this if you would like to keep your patient continent. So by Andrea Bischoff, this study of a group of patients who came to their center to study the reason for incontinence after Hirschsprung disease surgery. It's published in the Journal of Pediatric Surgery. And when they studied their patient, you find this absence of the sensitive anal mucosa in all these cases. You can hardly expect, you see a lot of perianal excoriation and incontinent child because of loss. Even if the muscles are still there, you have seen loss of the sensitive, very important piece of mucosa down there. You don't like at all to get this drastic, and I believe it's hardly and very importantly avoidable complication. So what is the proper technique is simple, because when you apply the hooks, you apply the hooks above the dentate line. You've applied first, and then you apply a second application before putting your stitches, traction stitches, well above 1.5 to 2 centimeters above the dentate line. That's how you protect the dentate line area and the sensitive anal mucosa within the hooks or the stitches you are using. Actually, what happens in the first 10 minutes of your operation can affect the whole life of the patient. So you need to be careful at the start of surgery on deciding when exactly you start your incision. Now we come to the problematic cuff of SOAVE. SOAVE is a very popular operation. And then this published by Mark Levitt in Journal of Pediatric Surgery on the problematic SOAVE cuff in Hirschsprung disease, manifestations and avoidance, treatment, and so on. And if you look at this X-ray, you see a problematic cuff causing stenosis, curling in of the mucosal cuff, and obstructive manifestation. So the important question comes now in SOAVE pull-through. What is the length of the seromuscular cuff you prefer to choose? Now we will shoot the second poll question, please. Yes. Would you like it to be more than 8 centimeters, 4 to 8 centimeters, or less than 4 centimeters? Of course, you know, the most difficult part of the submucosal dissection is the starting part. And whenever you go higher, then you can go much easier. So it's very tempting to go and proceed. So when to stop? What is the ideal length of the cuff? Now we'll share the results. Yeah, these are the results here. We can see that the majority will choose either less than 4 or between 4 and 8. And this is nice because the longer the SOAVE cuff, the higher the percentage of complication. So let's see here. This is the recommendation is to have a short cuff, but how short is short? What do we mean by short cuff? And I don't incise, I stopped incising the cuff, and avoid inverted cuff because during the operation, the cuff will invert inside. So be sure before you finish your operation, you return the cuff back by putting a non-toothed forceps in 4 quadrants around the pulled colon through. So 6 centimeters is a short cuff. Sometimes they recommend it to have 4 centimeters and even less than 2 centimeters a cuff. That's according to Mark Levitt nomenclature. He's calling it, this is becoming something between SOAVE and Swenson. Let's call it SOAVenson. So the third question now is, what is your preferred technique? I know a lot of people are expert in doing the Swenson technique, DUHAMEL or SOAVE. So what is your preferred technique? It's very important, you know, because, okay, now you can vote Swenson, SOAVE, and DUHAMEL. I have an imagination for your response, but let's wait for the results. Okay, as I expected, the majority, 70%, will choose the SOAVE. It seems to be the most popular technique, but still a good number, almost 22% doing the Swenson and 35 are doing the DUHAMEL. I would like to say that each center has got experience in one of the techniques, and still all the three techniques are acceptable and they are giving good results. But in this study, there is a comparison between the transanal pull-through, SOAVE, and Swenson in pediatric patients with Hirschsprung disease, and it came to the conclusion that they are similar. As I said, Swenson, SOAVE, and DUHAMEL are similar in the long-term functional outcome. So if you are happy with one technique, then go ahead with doing it. But in Swenson, there is less blood loss and there is shorter operative time. I recently changed it from SOAVE to Swenson, transanal Swenson. Then how to avoid problems with the DUHAMEL SPUR. In this X-ray, patient have undergone DUHAMEL pull-through for Hirschsprung disease, and you see a big ficcoloma that is apparent here and in the lateral view, and it appears to be because of the persistence of the cuff. So in this important publication by Louis de la Tour and Jacob Langer, it's very nice publication actually. It talks about technique, controversies, pearls, pitfalls, and organized approach. It is a collective message on the safety in Hirschsprung disease, avoiding complications and achieving perfect result. And my personal technique in doing the DUHAMEL approach is to do a double application of the stapler. You can see application from below, because if you miss one part of the upper part of the SPUR, it will grow all the way and you'll end up with a complete SPUR. So I apply double application of the SPUR, one from below and one from above, like here. This is persistent spurous ficcoloma. This is one application from below and one application from above. One very distressing complication you can see, which is the twisted pull-through. It is, you can see it leading to massive obstruction here because the pull-through is twisted, and I would like to say this is completely avoidable with proper technique. So what I personally do during the surgery, I keep an Babcock clamp on the anti-mesenteric border of the bowel all the time during surgery to avoid the inadvertent twist of the bowel during surgery. What to do with the dilated segment and the sigmoid loop? In this diagram, you see the red line is you have reached to ganglionic bowel above the cone of transition. But would you cut here? Would you divide here at the red line? I prefer to go to the green line, where you can take all the dilated bowel out, and we'll see why. This is a sample. This is a narrow segment. This is ganglionic, by the way, ganglionic bowel. But when you see it during surgery, this is hypertrophy of the muscle wall. This is ectatic, dilated, and you can expect that it will not function properly post-operatively. So this is, you can see the diameter here, and here you are approaching almost normal diameter of the bowel. I resect all this segment, and as you can see here, this is what is done. This is in adult surgery, but very important to know that the rectosigmoid will work as a brake for the passage of stools. It leads to slow down, not only anatomical, but also electrophysiological. So like you are going in the U-turn here with your car, you tend to slow down. This is the U-turn in the sigmoid loop. It is leading to slow down, which is needed in normal physiological situation. But in Hirschsprung surgery, where you find a lot of patients post-operatively suffering from constipation, probably would like to get rid of this. So this is a pre-operative personal series, and this post-operative, and all the time I insist on having a straight segment at the sigmoid region with equal uniform caliber. And if you take an X-ray 24 hours later, you see nice complete evacuation of the bowel. So why we remove the dilated ectatic colon? Because it's dilated, hypomotile. If you examine it by biopsy, you see the muscle fibers are malformed. Constipation is seen in 22 to 40% of patients post-operatively. So you'd like to avoid this, and sometimes it leads to pseudo-incontinence. How to avoid ischemia of the pulled colon? This is the arcade vascular supply of the colon during Hirschsprung surgery. In short segment disease, all what you need to do is dissection of this segment, which is very close to the wall of the rectum. This is all what you need to do if you are doing transanal. But if you need in a long segment disease, you need to mobilize a piece of the bowel. You need to be very careful. Your dissection will go here so that you keep the marginal arcade, which is the blood supply to your pulled colon. So in short segment disease, you need to stick to the wall of the rectum. But in long segment disease, you need to mobilize a segment. You need it to be very well vascularized. This is nice publications comes from Izmir, Turkey, on how to anastomose when you have a discrepancy of the bowel. Normally, in many occasions, you can see the colon is dilated even after excision of the most dilated segment, and you'd like to get this to the anus. So maybe a bit tricky. But what you do, and actually, is you distribute the discrepancy evenly in a democratic way. So you start by doing 4 quarters suture to distribute the controversy or the discrepancy equally, and then in between, you go again in between and in between until you finish it. And this nice diagrams comes from the Turkish publication. You can see it is well distributed to avoid discrepancy of probably 4 to 1. Now that you are coming to the end of surgery, would you like to put a rectal tube or not? Now we put the last question. Would you like to put a rectal tube post-operatively or not? Again, as I expected, only me can see the results of the poll by now. But we'll keep it to avoid affecting your choice. Now we can end the poll and see the results. Yes. Can you share, Tamer, the results? Not this one. Well, I'll tell you the results of the poll that 75 would not, yes, this is almost 80% will not put a rectal tube. I know this is feasible, but let's look at this recent publication again. This is a multi-center prospective study on using or not using the rectal tube. And it has, this is 2020 in the Journal of Pediatric Surgery, has recommended that the use of rectal tube can reduce abdominal distension, enterocolitis, and the recurrence of enterocolitis post-operatively. I use it routinely and I find no problem from using it. And I think you may reconsider using it for maybe 5 or 7 days post-operatively. Now we come to a big problem post-operatively, which is a post-operative enterocolitis, which will happen in how much of cases? About 25% of the cases will suffer from enterocolitis. And you can see 25 to 37 in suffering from enterocolitis. 8 to 30% will suffer from obstructive symptoms. So what are the causes of post-operative enterocolitis? I would say that some of them are avoidable, like anatomical problems, obstructive problem, anastomotic stricture, DUHAMEL, SPUR, and long SOAVE cuff, twisted colon, or functional, like missed segment or dilated atonic segment, probably obstructive defecation. But you have to remember that some of them are unavoidable. How to minimize the postoperative enterocolitis? Well, this is again a prospective study on the prevention and management of recurrent postoperative enterocolitis. It studied the factors that claim to prevent postoperative enterocolitis. It was found that routine postoperative dilatation does not affect the stricture incidence, while routine postoperative rectal irrigations have possible role in the reduction of enterocolitis. Posterior myotomy, it does affect, but it leads to very high incidence of incontinence, so it is not recommended. Botulinum toxin injection in the short term, very good response, 77%, in the long term, 43% of the cases. And probiotic prophylaxis has no effect on reduction of enterocolitis. So ladies and gentlemen, if we come to conclusion and summary of this, in order to avoid soiling and incontinence, then this is my message: avoid too much stretch on the sphincter, avoid direct sphincter injury like what happens in Swenson pull-through, for example. This will constitute the motor parts of the continence. And again, you keep the very important sensitive anal mucosa. This is responsible for the sensory part of continence. And this is all in order to minimize or avoid the dreadful complication of soiling and incontinence. How to minimize postoperative constipation? You remove the dilated ganglionic segment. It is pathological. It is hypomotile. You need to take it out. And I take the whatever sigmoid extra loop, does not lead to any horrid peristalsis or diarrhea, but it remarkably reduces the incidence of constipation postoperatively. And this is an example of a segment with removal of the dilated ectatic segment. Then let's go quickly to some of the technical details. Not before 1 month. Preoperative dilatation is helpful. Short SOAVE cuff, short means 2 to 4 centimeters. Divide the SPUR by double application in DUHAMEL. Stick to the wall of the rectum in Swenson pull-through. And maintain the vascularity of the colon in mobilizing for long segment disease. And put a post-operative rectal tube. It is a minor addition, but it probably will help in avoiding a lot of complications. So this is a quick video of the technique of transanal pull-through. As you can see here, this was in 2003. A few things have changed since that time. The field is completely bloodless with the use of bipolar scissor or hook monopolar diathermy. This is the dissection of the submucosal cuff in SOAVE by combination of sharp and blunt dissection. Now you go for the full thickness plane of this section. You incise the seromuscular cuff, and now you have to divide the mesenteric vessels to gain length. All our dissection, as you agreed, is on the wall of the colon and rectum, especially in the part of the lower rectum and anal canal. This ligation can be replaced, of course, with a ligature or harmonic scalpel to speed up the surgery. The surgery is in mean of 90 minutes can be finished. Now you reach well above the cone of transition, and here you can see a massive dilatation of the bowel. You continue here, the mesenteric vessels are long, and you can see the whole segment around 40 to 50 centimeters. This back incision of the seromuscular cuff, I don't do nowadays. You don't need it, especially when you are using a short seromuscular cuff. When you do the trimming, make sure you are not pulling too much on the colon to create tension on the anastomosis, and don't do it all the way at one time to avoid slipping of the pulled colon upwards. You do a careful coloanal anastomosis by a double layer of suturing. And as we said, if you go up to a near normal diameter of the bowel, then you can minimize the discrepancy at that time. Now you can trim the last piece and finish your anastomosis. Make sure it's secure anastomosis. There is no discrepancy. And you can see very well the piece of inner mucosa of good length above the dentate line. This is a segment excised around 35. This is the length of the seromuscular cuff. It's around 6 centimeters at that time. But now I'm tending to have less length of the cuff or even Swenson procedure. So if you follow the guidelines and instruction, you'll have a happy colon. If you have a happy colon, you will have a happy patient at the end. I would like to remind you that in Swenson procedure, you need to stick to the wall, exactly to the wall. In SOAVE procedure, you are working inside the wall, so keep it a short wall. And in DUHAMEL procedure, you are working behind the wall, so make sure to remove the whole wall. So I will be happy to answer any of your question. I didn't find a better question mark than this photo. So I'll be very happy to answer any of your question. And if you need any further communication, please record my email and phone number. Thank you very much. And thank you again to Aydin and the Turkish pediatric surgeon for this wonderful invitation.
Well, Sameh, thank you very much for this nice presentation. You demonstrated us a clear view of ongoing debates with a strong support of the evidence-based literature. I'm sure there will be questions from the audience. So I'm looking the participants, and one is coming from Meltem. She's from our department. So I'm unmuting them. Yeah, Meltem, you can ask question. Meltem, I'm trying to unmute you, but yes.
Yeah, that's okay. Dr. Sheata, hello.
Hello.
It's great pleasure to have you with us and listen to you. It was a great talk, as always. I have two questions. One of is, once we listened to Dr. DeLaTorre in SPS meetings, and he told us that he always operates on prone position, like doing posterior sagittal anorexoplasty, because that's how he made sure that he's on the midline and he can see the meso of the colon properly. I can tell from your video you operate on spine position. What's your comments on the position of the patients, and when do you use laparoscopy or when you do laparoscopic assisted pull-through? The second question is, when you remove the rectosigmoid colon, you pull a very straight colon, and in these patients you cannot have the rectal angulation, and you cannot have the rectosigmoid reservoir function. And do you think this has a negative impact on future continence? Thank you very much.
Thank you so much. Actually, these are three very important questions, and I'll try to answer briefly. I know that Dr. DeLaTorre will prefer the prone position, but there was an argument about this for some reasons, because sometimes, this is your third question or second question, sometimes you need to convert to laparoscopy. And if you try to change the position, it will be difficult. And we don't find actually a problem on operating in the supine position. So my own preference is supine. It was a little bit not direct to the mesentery, as you said, But the great advantage, if I'd like to convert, it's very easy. You go to laparoscopy. This is for the prone position. When you go for laparoscopy, there are two reasons. Number one, in long segment disease, of course, you will need laparoscopy to mobilize the colon and divide the splenic flexure, the splenocoelic ligament. But again, you can do it in short segment disease when you cannot reach to the level you would like to go. For example, if there is a huge colon, or there is short sigmoid mesentery, you cannot reach to a level you would like to reach, removing the whole dilated segment, you reach to a very convenient level, then you go immediately to mobilize by laparoscopy. Regarding the straight rectosigmoid, it's different from the endorectal angle. These are two angles, actually not single angle. One is the rectosigmoid and one the endorectal angle. If you know that in many publications, intractable constipation is troublesome in many of Hirschsprung patients, from 22% to 40% to 60% in some series, then you would like to remove any breaks in the way, any redundancy that might lead to rectal prolapse in the future. So by removing it, I'll show you now my results in my series. I have a low incidence of constipation postoperative. I don't have diarrhea or frequent passage of stools. So I prefer and I insist on removing the whole of the dilated segment, the whole of the sigmoid loop, make it straight as you have seen it. I didn't regret it for the last 15 years, but other people are regretting the constipation, which is intractable and you cannot. I remove the rectosigmoid angle, but I keep the puborectalis angle. Thank you so much.
Thank you very much.
Sameh, there are some questions from the audience, and one of them is coming from Farid Alagi. He is asking, Hirschsprung is a histopathological disease, and for diagnosis, you start with contrast, water-soluble contrast, or by full thickness biopsy, rectal biopsy?
Well, this is a strategic question. In order to get, first I would like to say there are some fallacies of biopsy because of inadequate biopsy or because of complications of biopsy or because lack of expertise in reading the biopsy. So if you'd like to get the ideal for diagnosis is a combination of contrast enema and biopsy. But there are many interesting publications around the world of saving or minimizing the need of biopsy when you have an unequivocal and definite diagnosis by contrast enema. The contrast enema, if well performed and well read, and in more than 70% of the cases, you can see a definite evidence of Hirschsprung disease, not only the disease, but also of the level. And there is a publication from Egypt on minimizing, I'll send it to the whole group, how to minimize biopsy. You do it only when indicated, but when you have a definite unequivocal result on contrast enema, you can go and you prove this by intraoperative frozen section biopsy and postoperative biopsy. It proved to be reliable. Of course, it cannot be generalized, but it is nice to look at the publication.
Well, Sameh, it's related with this question also. Do you ever use laparoscopic seromucosal seromuscular biopsies, and you do this transanal pull-through with a laparoscopic aided transanal pull-through?
I do it only in suspicious cases, because if you combine visual observation and contrast enema before surgery, and you have a definite diagnosis of Hirschsprung disease, I confirmed this by post-operative biopsy in all cases, confirmed that my personal judgment was correct. When I use it, when it is questionable, in 20 to 30% of the cases, you cannot be sure of the level, you cannot be sure of the diagnosis, the contrast enema results are not sure, then of course, definitely you need to have multiple biopsies, either by open or laparoscopic, frozen section or routine biopsies.
Okay. There's a question from Rodolfo Soto Ravelo. He's asking, no matter what the technique is, do you recommend to use the rectal tube in all cases?
Well, my personal experience and my personal recommendation, I've been all the time using it. I never regretted the using rectal tube for some simple reason, because it overcomes the resistance of the sphincter when your anastomosis is still fresh, especially if you have watery stools post-operatively. Then I didn't regret at any one moment. This is personal experience. When we come to the systemic survey and meta-analysis, it has proved that using rectal tubes is better.
Okay. Okay, there's a question from Abbas Al-Hassani. He's asking is about the initial end-to-side anastomosis in DUHAMEL's pull-through operation. What's the best choice, hand sewing or circular stapler? But we use, I think, linear staplers, not circular, yeah?
There are two anastomosis actually. One of them is end to side, where you can use a circular stapler, and the other one, which is crushing the spare side to side colorectal anastomosis, we can use the linear stapler. If you are very rich, I don't know who is asking from which place. If you are very rich, you can use two staplers, one circular and one linear. For me, I use the hand sewn for the end to side, and I use, of course, the linear cutter for the side to side.
Okay, one other question is again the same guy. He's asking, what's the best option in the management in the absence of frozen biopsy intraoperatively? If you don't have a frozen biopsy possibility.
Well, if you are, again, if you are sure of your diagnosis based on strict performance of contrast enema and strict criteria which prove to be correct, then probably you don't need a frozen section biopsy, but you confirm by post-operative routine biopsy. But in case of doubt, you don't have a clear level or clear diagnosis, then you can do a routine biopsy and wait before doing surgery. Do a mapping of the colon to know exactly where you are going to resect.
Okay. Another question from this time from Turkey, from Mete Kaya. He's asking, the biggest advantage of SOAVE is not doing a perirectal area dissection. So how do you avoid the neurovascular complications? How do you do it in a technical way in Swenson?
Yes. I have been doing SOAVE for a long period of time, but recently changed it since 5 years to Swenson. And the secret about Swenson, of course, you know, this was the first operation. This was a prototype, and it is logic. When you need to remove the rectum, then you go and remove the rectum. You don't dissect the wall. But the trick, very important, is you stick all the way to the wall of the rectum, exactly, as if you are taking the adventitia out of the rectum. If you go 1 millimeter outside, then you are asking for complications, either for the neurovascular bundles or the vas or others. So it needs some degree of experience, but at the end, if you master it, it's a wonderful operation. Shorter operative time, less blood loss, and you avoid all the problems with the SOAVE cuff.
Okay, there is a question coming from Khalid Sharif. Yes, you can go ahead and talk.
Hello.
Hello,
Hello, good morning.
Hello, Sharif.
Yes, and Dr. Sameh, thank you very much for your very nice presentation. You are as glamorous as usual. It was very clear and comprehensive. Yeah, I have two questions. First question about the size of the rectal tube that you will use after post-operative surgery. What the size? The second question is about the terminology, which is ultra short segment. Do you believe that there is what's called ultra short segment? Because sometimes we'll have confusing cases. We have the clinical picture of Hirschsprung disease. The patient have equivocal radiological signs, and histopathology is not conclusive. So I think the only solution is to say it's ultra short segment. And if you agree that it's there, you will proceed for transendorectal breakthrough, or what you will do. Thank you very much.
Thank you very much, Khaled, for your questions. For the rectal tube, it depends, of course, on the age of the patient, but normally for 6 months age, it's 16 to 18 French. For the ultra short segment Hirschsprung disease, it's highly debatable entity, and it can be very much confused. You cannot radiologically be sure of it. Histology is difficult because this region, there is normal hypoganglionic zone. You cannot confirm it. Probably by using manometry, and you see absence of endorectal inhibitory reflex, but this is not confirmed. So I prefer not to use the entity of ultra short segment Hirschsprung disease, and you treat it as intractable functional constipation. Intractable functional constipation has generally two lines of treatment, either conservative and the patient will improve, or intractable where you will need to do surgery. And for surgery, you need to resect the mega rectum, which is hypotonic and non-functioning, and you do something not as a Hirschsprung disease, but as a functional intractable constipation, only intractable.
Okay, thank you. And there is another question coming from Gamal Al. I couldn't read the surname. So Gamal, you can ask your question. I'm trying to unmute you. Yes. Okay.
Gamal Al-Said from Said.
Yes.
Thank you, Professor Sameh, for this nice presentation and the valuable advice for all of us. Thank you very much.
Thank you very much.
My query here: what is your approach in a case presented in the neonatal period with severe type of enterocolitis? Do you recommend just rectal tube and the medical treatment, or to go for the for whatever open or laparoscopic biopsies and colostomy like this? What's your experience in such cases?
Very important question, Professor Gamal. Actually, you know that the major mortality of Hirschsprung disease comes from enterocolitis. And those presenting in the neonatal period are very risky and very critical. So immediate hospitalization, ICU management, rectal tube is of paramount importance. And your decision now, maybe your question is whether you go conservatively or you do a colostomy. Well, in order to save from doing a colostomy, if the patient is very rapidly improving and can be maintained and tolerates, first you control the infectious episode and toxicity, and patient can tolerate oral, I wait for 2 months to do a one-stage procedure after confirmation of diagnosis. But if the patient is not improving in 48 hours, then it's time for urgent colostomy. This is life-saving, and you don't save a colostomy for the life of the patient. So a serious patient not improving adequately on conservative measures, right away you go for colostomy.
Okay, there is another question from Turkey, Canan Ceren. She's asking, during transanal pull-through, recommended distance between anastomosis and the dentate line is 1 to 1.5 centimeters. Along with the normal growth of the baby during a year of age, this distance became longer than 3 centimeters. I wonder your experience for this.
Well, here you are between two extremes. One of them being too low near the dentate line and you risk soiling, and the other one leaving too long piece of mucosa above the dentate line, and you risk a short missing segment and obstructive manifestations later on. So these are two extremes. We'd like to be in the middle. Number one, it's difficult during surgery to get a long, if you try, I always try to get a longer segment, and at the end of the operation, I find it barely 1 centimeter. So between 1 and 2 centimeters is good. And this region is normally hypoganglionic in the normal individuals. So between 1 and 2, even if it will grow further on, there is no problem, does not lead to problems. But the main problem is having soiling if you have less than that, or you encroach on the anal mucosa.
There are some questions regarding the rectal tube, the size of the rectal tube, and how many days do you make it stay there? How long?
The size, it depends, of course, on the age of the patient and the size of the patient, and you can measure it by the same size of the anal dilator you are using to dilate the. There is a table for the sizes of the. As I said, in 6 months, I can put 14, size 14 or 16. For how long? It's between 2 and 5 days. You can put it so long as it is draining. Then you are having benefit of avoiding the contact between stools, especially watery stools, and anastomos. I never regretted putting a rectal tube, but probably not using a rectal tube can lead to problems.
Okay, thank you. And there are questions, last questions. Mohammed Al-Zohiri. He's asking, what are the indications of post-operative, post-puncture rectal biopsy? And a continuing question is, what's the indications for redo operations?
Redo operations, of course, if you have anatomical problem that is leading to intractable symptoms. So, for example, if I have persistent SPUR or stenotic anal stenosis that is not responding, most of them is missed segment. Of course, this is a clear indication for redo surgery, or intractable constipation or enterocolitis postoperatively due to retention of a dilated segment. These are the indications for surgery. Of course, redo surgery for soiling and incontinence probably is not useful, because if there is destruction of the sphincter, this is very difficult to repair. That's why we insist on keeping the sphincters and the anal mucosa intact at the first surgery. But for intractable symptoms with anatomical or physiological, like missed segment, then you need to redo. But be careful that redo is associated with higher incidence of incontinence.
Yeah, okay. And one question is, even though you care about all the things you mentioned, sometimes some of the patients could have some minimal soiling. What are you doing in this kind of patients?
Well, it has been reported in one of the publications that soiling is up to 37.5% in the first year, and then it goes to around 15% afterwards. It improves with time remarkably. So number one, you need to assure the parents that this is something that even at the first 3 months after surgery, the frequency of stoolings comes to maybe 10 times every day. This is normal with some soiling. But after 1 year, usually this comes down remarkably down to a very much lower degree. I would like only to make sure that this soiling is not the result of retention overflow, like spurious or false pseudo-incontinence resulting from retention. So we make sure the patient is continuously evacuating properly.
Okay. Sameh, there's a question from Abbas Al-Hassani. So I unmute him and he's going to ask, yes. Abbas, we are listening to you.
Okay, thank you, Dr. Sameh. I'm Dr. Abbas Hassani from Iraq. My question is, in certain neonatal presentation of Hirschsprung disease, the patient doesn't respond well to the conservative management, and you have to do colostomy. During laparotomy, what is the site of colostomy or ileostomy? Do you prefer a blind transverse colostomy or ileostomy? And thank you.
Thank you very much, Dr. Abbas. Of course, there is a group of patients who are not improving on conservative treatment. They do not have enterocolitis, but they are failing to tolerate oral feeding, and they are below the age of, let's say, 3 weeks. Of course, it is possible to operate, but there is much higher incidence of complication. So for these patients, I prefer to do a colostomy. What type of colostomy? Definitely a leveling colostomy exactly above the cone of transition. If you do a blind right transverse, then this is a mess. You lose a big length of the bowel. You make life very difficult in the second operation. So you better do a leveling colostomy exactly above the cone if the patient cannot wait.
Sameh, there is a question they're asking, do you have a threshold or a minimum weight to do the pull-through?
Yes, it's it all related to the weight of the patient, the age of the patient, and size of the anus. So normally I prefer to operate between 2 and 3 months of age. That's around 4 to 5 kilograms of body weight.
Okay, and what's your recommendation the patients who had a colostomy before?
For the timing, you mean for surgery?
No, the technique of the surgery, if he has a colostomy.
If he has a colostomy, I do a hockey stick incision, including the colostomy site, which is usually in the sigmoid colon, unless it is a longer segment disease. And I do transabdominal with transanal Swenson procedure.
Okay. And there is again Khalid Sharif who would like to talk and ask you a question. So I unmute him. Yes, go ahead, Khalid.
Yeah, I'm sorry. I'd like to grab the opportunity to ask Dr. Sameh with a very great opportunity here. It's about the post-operative necrotizing enterocolitis. The first question, do you prefer or suggest to use the metronidazole for longer period, in the post-operative period, I mean for months or years? This can reduce the incidence of occurrence of necrotizing enterocolitis? Is number one. Number two, sometimes on those child who are less than 1 year of age, the anal tone is very high. And this is one of the cause of the development of the necrotizing enterocolitis. Do you prefer to make the regular dilatation, or do you use Botex, or do you ignore? Thank you.
Thank you very much. Important question. As we mentioned, post-operative enterocolitis either avoidable with some correctable causes. You have to check before treating that the patient does not have a cause for enterocolitis, which is obstructive manifestation that can be corrected by surgery. So you do contrast enema and make sure you don't have stenosis, missed segment, or whatever. If it is of the unavoidable type, where you can find no reason for enterocolitis, then you go for medical treatment, which ranges from rectal irrigation through rectal tube. This has been proven to be effective. The prolonged use of metronidazole, and I usually put a rectal tube during the acute attack. This relieves very remarkably the attack quickly. And you have to know that sometimes there is intractable enterocolitis post-operatively that is unavoidable and not responding to medical measures and life-threatening to the patient, that you might need to do a colostomy for some time. Some minority of cases are intractable, whatever you do.
And Sameh, there are some questions. When do you start feeding the babies?
After transanal pull-through, normally after 3 days.
Okay. And one question from, again, Turkey, from Meeting Gündüz. He'd like to ask you about more detailed information regarding the Botox injections.
Well, the Botox, I don't use it personally, but in the meta-analysis I have mentioned, it is proven in obstructive manifestations. If you have a non-relaxing internal sphincter with either constipation or enterocolitis, it's very useful. 77% in the short term and 34% in the long term. It declines a little bit with repeated use, but it's very useful. Of course, it's not recommended that you do a myectomy or myotomy, because it leads very high incidence of incontinence. It relieves, of course. There are two things that cannot go together. You don't have continence with, incontinence with enterocolitis. Either you have one of them. If you have incontinence, you don't have enterocolitis. If you have enterocolitis, you have good continence. So never do a myotomy or myectomy. Botox is a good option. I have no experience in it, but it's a good option for obstructive manifestation.
Sameh, thank you very much. We really learned a lot. All of the things you have told us were evidence-based, like we like it. Hope to see you in healthy days. And I'd like to say everybody to stay safe. And I also share our YouTube channel, and this presentation is recorded, so we are going to publish it there, so you can be able to watch there, and we will also distribute it in the social media, so any people who cannot be able to be here and listen you today, can be able to go ahead and watch you online. Thank you very much. We appreciate it.
Thank you so much, Aydin. Great pleasure and privilege to be with you today with all this wonderful audience from different parts of the world. Perfect organization. The questions are actually very stimulating and indicates a lot of experience of the audience. I enjoyed very much this interaction. I hope that we'll meet in real life after this all is over, but we'll continue to have more and more of these online meetings. So thank you very much and looking forward to our next meeting.